Yeah.
Trước khi thầy báo cáo, bác sĩ Giang cũng giới thiệu một chút xíu về thầy. Thầy là giảng viên của trường đại học Chulalongkorn, và thầy cũng là phó chủ tịch hội giải phẫu bệnh quốc tế ở khu vực Thái Lan. Đồng thời thì thầy cũng là giám đốc trung tâm sinh học phân tử của Chulalongkorn. Thành ra là thầy rất chuyên về sinh học phân tử. Thành ra hôm nay thầy có 2 bài báo cáo, một bài báo cáo về giải phẫu bệnh và u não, và một bài báo cáo về các cái xét nghiệm, đặc biệt là sinh học phân tử. Thầy có 2 bài, thầy được xem như là key person của buổi sáng ngày hôm nay. Please.
Xin lỗi cho cô giới thiệu thêm về thầy Shanop. Thầy Shanop Shuangshoti là hội viên danh dự của Hội Giải phẫu bệnh Thành phố Hồ Chí Minh ạ. Thầy đã rất là nhiều bài báo cáo tại các hội thảo do Hội Giải phẫu bệnh Thành phố Hồ Chí Minh tổ chức, cũng như Hội Giải phẫu bệnh tế bào bệnh học Việt Nam, là một người bạn rất là thân thiết của tất cả các bác sĩ giải phẫu bệnh Việt Nam. Xin mời thầy.
So, thank you very much. Good morning, Dr. Yang, Professor Ha, Professor Thao. It's my honor to be here again. So I have 2 lectures, and the first one will focus on morphology. Nothing about immuno, nothing about molecular. And so it's pure morphology. So how many of you read brain tumors? No? Okay. Okay, I think this is a fact. You cannot diagnose tumor that you haven't heard about it. It's the same, pathologists and clinicians, right? So if you want to diagnose brain tumor, you have to know all kinds of brain tumors. And the easiest way is just to go over the WHO, the whole book. Okay. And memorize the pictures. Sorry. Okay. So I think if you are doing microscopy, it's about mapping the pictures. This is not AI. This is through snake. Can you make the diagnosis what a species? Nope, right? It's, I don't know, but it's a hairy bush viper. You have to memorize this in your brain. And one day you see it, you know what it is. This is exactly how pathologists work. You have to memorize the pictures. But the problem that now I have trouble with the online WHO books. How many clicks you have to make to see all the pictures? I think the old version book is very easy. You have a book and you open every pages and you try to memorize all the microscopy. That I did when I was younger than this. So I open up the AFIP fascicle and I try to memorize all the pictures in my mind. And sometimes when I see the real case, I go, oh, it's on this page, left side, right side, and I just open the book. Okay, so to me, to be a good pathologist, you don't have to know about pathogenesis, but you have to be good at morphology. If you know a lot of pathogenesis, but you are poor at morphology, it won't make you a good pathologist. You can do research, but not a good pathologist, okay? And the common pitfall, what is a common pitfall? Imagine you don't know the tiger. One day you see the tiger, you're gonna think on your mind what look like a tiger most in your mind, in your experience, and you will miss tiger for a cat. This is a common mistake. Same with the clinicians, okay? And we talk a lot of the hallmarks, features. When we learn in the medical school, we might remember Homorai rosette. You might remember Lichtenberg cells. When was the last time you see the typical Lichtenberg cells? Or when was the last time you see the the rosette, the classical rosette that nobody argues about it. So we learn a lot of all the hallmarks, but to be a pathologist, you have to pay attention on the non-hallmark. Okay. In other words, you should be recognize that this is a kind of the small cell tumors, malignant. It's not lymphoma by H&E. You have to tell that. Okay, and you have to recognize medulla before the tumor cell form the rosette, because you're not going to see rosette in every medulloblastoma unless you hallucinate yourself. Some people say, "Oh, we see the rosette," but some people may disagree, right? So rosette is not common in medulloblastoma, and you have to know the entity very well. Sometimes you have to exclude diagnosis by exclusion. Sometimes I see some case. I look at the slide and I think this is unusual. I haven't seen this before. But to say this sentence is, you need to have a bunch of knowledge in your brain. So sometimes you have to diagnose by exclusions. That's why you have to know all the variation of the disease. For example, GBM, you have to know all the variations of the morphology. And I think this is true also. Difficult cases teach you more. But most of the time, if we are too busy, we don't want to keep the difficult case, right? We want to hand the case to someone else to do it. And then we lost a chance to learn. So don't make yourself too busy, you know. If you are too busy, when you see difficult case, you're gonna send the case to someone else. And I think although we have many techniques, now you know, I can show you in the second lectures. I think the methylation is amazing. I tell you in the second lectures, but we still have morphology we should be skillful as morphology. And this is a book I like, but I don't agree with him 100%. So this book was written by Malcolm Gladwell, and he estimated that if you want to master something, you have to spend time 10,000 hours on that subject. Which means if you want to be a musician, you want to play music, you have to practice 1 hour. It would take you 27 years to become the master. And if you practice 2 hours, this is a year that you have to spend to become the master. But many people disagree with this because 10,000 hours is not enough. Because you have to know the direction how to practice. Let's say you are a pathologist, you spend 10,000 hours reading PDL1. It won't get you anywhere, right? You spend 10,000 hours reading appendicitis, gallbladder, scoring HER2. It won't make you master in morphology. You have to have a direction. So I have suggestion for you, for the young pathologists. Not yet. So for tumor pathology, I think we have 4 components to look at. One, we look at the tumor architecture pattern. We look at tumor cells. You can describe it as brown cells, pleomorphic cells, spindle cells. And non-neoplastic cell, I mean, are the matrix, right? Matrix in the tumor cell, chondroid, myxoid in the tumors. And sometimes you have a normal cell within the tumor that can be clue to diagnosis. And you have to interpret this, the whole pictures. It's easier said than done, but you have to interpret the whole pictures. So how you build your 10,000 hours, I have recommendation. You have to learn the morphological spectrum of the tumor entities. You have to build your mental library of the microscope in your brain, which means you have to look at the book, open all the book, memorize all the pictures. And this is, I'm routinely doing this. I'm examining slide without the clinical first. And look at the low power and then go high. And as I mentioned, you have to pay attention to both hallmark and non-hallmark. And this is, I'm doing this all the time. Challenge myself when you put the slide on the microscope, only one or two field you try to make diagnosis. Okay, sometimes you can make diagnosis in one field that you see on this microscope. This is also fun. Gloss examination is very typical. It is still helpful. So can you guess the diagnosis? Can you match it? So in A, you can see that the tumors, the lesions mainly in the cortex, and you can see the mucoid background. The white matter is normal. So from the 4, I think A is typical for DNET. For the B, when you do the cross section, don't describe as everything gray white. For the brain, you have to describe the gray and white junction, whether it's sharply demarcated. So you can see that in this area, the gray white junction is very sharp. In this area is blur. So there's something infiltrative going on here. So B is a typical feature of low-grade diffuse glioma. And the C, the lesions mainly in the cortex, and if you can touch it, it's very hard. And this is the typical feature of FCD or cortical tuber. And the D, you can see the yellow one, yellow color, and the lesion is very superficial, involve the subretinal space. So this is typical of PXA. So you can, cross examination is still very important if you have a big specimen. This is my favorite. Usually I usually pick up the slide and try to guess from the naked eye. This is a typical meningioma, right? Dural-based tumor. What about the B? You can tell right away is a round cell tumor. Spindle cell tumor cannot make these pictures because this is a very round cells, little cytoplasm, because the blue, because of the cytoplasm, is very little. So the nuclei is packed together. So if this is from the cerebellum, you can tell it's most likely medulloblastoma, and it is. What about this one? This is a cerebral cortex. You cannot see the gray white junctions. So it is a diffuse glioma. So you don't need a microscope. This is a recent one. So I saw this. This slide is taken without a microscope. So can you guess? The question I asked the resident is whether the patient has colon cancer. You can see all the pink one is necrosis, and the tumor is cluster and is very blue. So this is, I just guessed. So this is a metastatic colon cancer. It was correct. And this is a histology. So you have a lot of necrosis. You have all the glands. So I just guessing, the more you guess, the more chance you get the correct diagnosis. If you don't guess, you don't get any. Okay, so this is a traditional approach morphology that I learned from the AFIP. If you old enough, you know the AFIP, right? In 2000 was at the AFIP, and they taught me that first you have to determine whether it is normal, abnormal, then tumor, non-tumors, and tumors glial or non-glial. So I modified it. So it's up to you, but this is my modification. So first same normal versus abnormal, and then the second I determine whether it's a neuroepithelial neuroendocrine or not. I know that neuroepithelial and neuroendocrine are very different, but they have a morphological overlapping. If you think of a small cell carcinoma and a medulloblastoma, they look the same. I mean, by H&E. If you go high powers, you cannot tell whether it's a medulloblastoma or a small cell carcinoma. I can show you later. And then if it's a tumors, I try to, if it's a neuroepithelial, then I determine whether it's tumor or gliosis. And when you say gliosis, you have to try to look for the cause. Sometimes you can find it, sometimes you cannot. Okay, normal versus abnormal. You have to know that in some certain part of the brain, they have a lot of cells. Okay, and that includes the granular cell layer of the cerebellum, collar plexus, pituitaries, and pineal. So this is a normal pituitary gland. You can see a lot of cells. Sometimes a pathologist has a common sense that anything is hypercellular is abnormal, and that cannot apply to all part of the brain. So this is one part of the brain that normal is have a lot of cells. But you can appreciate the lobular architectures of the pituitary, and you can see that the cells, endocrine cells, they produce different hormones, so they have different cytoplasmic colors. So this is very normal. And if you do a reticulin stain, you can have the lobular architecture preserved. But this is a pituitary adenoma. So first, you cannot circle all the lobular architectures, and the cells are very monotonous. And if you do reticulin, the architecture is disrupted. So this is a normal. This is pituitary adenoma. But actually, you don't have to do reticulin because by H&E you can tell. Okay, most of the time, reticulin is just to show the pictures, but usually I don't use it. This is another pituitary. You can see that is a perivascular pattern, and you cannot circle around the lobular architecture because it disappears. This is another pituitary with a perivascular pattern, and you cannot appreciate the lobular architectures. And the cell look monotonous, so you can make diagnosis without the reticulin. You think it's tumor or non-tumors? Non-tumors. Yeah, it looks very hypercellular. Yeah, this is actually is a high power of the granular cell layers of the cerebellum. So if you just go low power, you won't miss it. But sometimes in the smear, sometimes it can be tricky on the smear. So this is a pictures of the medulloblastoma. You can see tumor cells admixed with the granular cell. So when you have a reference cell, you can see that the granular cell is much smaller than the medulloblastoma. What is this? What is it? This is another normal. Normal. It's normal. It's abnormal. This is normal pineal gland. It's still normal. Okay, because it's very hypercellular, right? Yeah, but this doesn't pose much trouble because usually we don't get the normal pineal from the specimen. Pineal in the pineal region, you get the tumors, right? Germ cells, pineocytomas. Usually you don't get the normal pineal gland, but you can get normal pineal gland in the pineal cyst. Pineal cyst is non-neoplastic and no epithelial lining. And sometimes when they remove the pineal cyst, you get the normal pineal gland. And don't miss it for the tumors, because it's not gonna match with the imaging at all. Pineal cyst and pineocytoma. You can make it pineocytoma, normal gland. If you stain NF, it's going to be positive. But in real practice, it doesn't pose much trouble, okay, because you don't get it. But to be aware that this is normal, it has a lobular pattern. And in the pineocytoma, you don't have the lobular architectures. This is normal, okay. This is a normal coral plexus. This is a coral plexus papilloma. What is different is in normal coral plexus, epithelial cells tend to be rounded, okay. But in the papilloma, it's flattened. But in real life, you don't miss it because it's very typical. The cross, you have very cauliflowers, and you have abundance of the papillary. Okay. Another thing is, I think this can be misdiagnosed, is just a congested blood vessel or hemorrhage. Hemorrhage may be from the surgery, and sometimes you get the leptomeningeal blood vessels, no brain surrounded, no surrounding brain. Sometimes you miss it for the vascular malformation. And the surgeon will be surprised if you call it AVM. And so I have seen some pathologists make a mistake, make the diagnosis, and the surgeon didn't believe because they didn't see any AVM. But remember that AVM or carcinoma usually sit within the brain tissue. Okay, it's not just floating around. Okay, so AVM. So that we have a four classes for type of the vascular malformations. It's good to classify because only AVM and carcinoma that we can see on the surgical sample. The capillary telangiectasia and venous angioma, most of the patients are symptomatic. So we're not going to get it on the surgical specimen. Usually we can get it from an autopsy. Okay, so this is a typical AVM. You can see that the blood vessels are within the brain tissues. And both AVM and carcinoma, the brain, the adjacent brain is not normal. It has to have evidence of the previous hemorrhage or gliosis. Okay, so this is an AVM. You can see the artery and vein embedded in the brain tissues. This again, I don't do it normally, but if you do a elastic, you can identify artery with the internal elastic lamina and the vein without the internal elastic, but there is no need to do it. You can make AVM diagnosis without elastic stain. For the carcinoma, you have only vein and no artery. And again, you have the evidence of the old hemorrhage. Okay, so that's about normal versus abnormal. And then we move to how to distinguish between the neuroepithelial and non-neuroepithelial. So I still use the word neuroepithelial tumors when I'm not sure whether it's a glioma or it's an embryonal. I know this word may be not seen in the WHO, but in Thailand, I have to make diagnosis from H&E first and make a recommendation to do additional workup. So many times when I'm not sure whether it's a gliomas or it's embryonal tumors, I still use the word neuroepithelial tumors. So there are features suggesting neuroepithelial lesions. If you see the cytoplasmic processes, you have to think of a glial. And glials that have a cytoplasmic process typical astrocytic and ependymal. Oligo, you can have some process, but not very distinctive. So from the H&E, where to look for the process is around the blood vessels. You can see the cells here, the process toward the blood vessels, small prominent here. You can see the central vessels and see the tumor cells sending the process to the central blood vessels. So this is very typical. You see here? So this is, when I see this, I know it's a glial. Okay. When you know it's a glioma, don't stain it with GFAP because it doesn't help. Okay. When you're sure that it is glioma, GFAP is not going to help because all glioma stain positively with the GFAP. Okay. Another feature is a gemicidocyte. Gemicidocyte is eccentric nuclei and abundant cytoplasm, angulated, quite a homogeneous staining of the cytoplasm. So this is another feature that suggests the astrocytic, or sometimes you can see it in the oligo. So which one is reactive? So this one is reactive. In reactive gliosis, the astrocytes tend to have abundant processes. And this is tumors. You can see that we have a nuclear atypia here. And this is what is called mini gemicidocyte in oligoendoglioma. So you can see that the tumor cells retain the round nuclei, but you have a little process coming out of the cell, look a little bit plasmacytoid. Okay, but if you stain GFAP, it's going to be positive. So this is called mini gemicidocytes in the oligoendoglioma. So this is a table that you can find anywhere to distinguish between glioma and local gliosis and local glioma. Cells like this may not be helpful. Okay, even though some of you may think that the glioma should have more cell than the gliosis, but for me, I think in some cases they are quite the same. The distributions in gliosis, the astrocytes tend to be regularly distributed, but locally is irregular. Sometimes it's very subtle. Atypia is more prominent in the local gliomas, but some gliosis also have the atypia. I think microsis may be more helpful. Calcification. I think the secondary structure is very helpful. Foamy histiocyte. When you see a lot of foamy histiocyte, usually you're not supposed to have a foamy histiocyte in the local glioma. But in the high-grade glioma with necrosis, sometimes yes. Okay, so this is a nuclear atypia. So even though this tumor cells, not many tumor cells in this field, but the atypia is very significant. So this is a feature of astrocytomas. This is a microcyst. You see microcyst is favor tumors. This is a case of a young boy, I think, with the clinical diagnosis of high-grade gliomas. And when we look at the case, it's not a high-grade glioma at all. So we have a gemicidocyte. And with this few two pictures, you can exclude the high-grade glioma. And this case had a lot of foamy histiocyte, has some perivascular lymphocytic cuffing. This is another non-specific finding. I don't think it's very helpful to pay attention a lot to the perivascular lymphocytic cuffing because it's quite non-specific. Another field show many formihistiocyte. So I did the Bischofsky stain, which is a silver stain. If you don't have it, you can use a neurofilament protein. You can see that in the area that has a formihistiocyte, axon is quite preserved. That make you think that it could be a primarily demyelinating, but you cannot make the different diagnosis of demyelinating disease on the pathology because it's not specific. So I cite the case out as a gliosis with proliferation of formihistiocyte and relatively preserved axon. And I suggest they should work up for a primary demyelinating disease. And it turned out to be by the clinical, and the patient received a treatment as a demyelinating disease and got improved. Okay, glioma or gliosis, the same case. So this is a very atypical, right? But the cellularity is very low. When you see something like this, you have to think about, you have to look for oligo inclusion. Any diagnosis. This is a progressive multifocal leukoencephalopathy. This is caused by JC virus in the patient with the HIV infection. And this condition is known to produce the atypia in the astrocyte. So don't look at the high power to see just one cell or two cell and make diagnosis. So this particular cell fulfill the criteria of atypia, but the surrounding pictures is not right for the tumors. Okay. This is very helpful. If you see secondary structures, so you can see that this is a cerebral cortex, and this is a pier surface, and you can see tumor cell accumulate under the pier. So the tumor cell infiltrate from the low white matter to the cortex, and it got stuck at the pier. So this is very helpful for glioma. And sometimes the tumor surround the neuron. So this is a subpier accumulations. This is a perineuronal satellitosis. And sometimes you can have the perivascular satellitosis as well. What about other tumor? You have to remember lymphoma has this pattern. Lymphoma can infiltrate into the cortex, surround neurons, but the cell morphology is different. Okay. And lymphoma, when they arrive at the subpier, they're not going to stop. They're going to go into the sublunar space. Okay. So just lymphoma is a differential diagnosis, but you can tell by the cell morphology. Medulloblastoma can do this, but it's in the cerebellum. So when you look at the tumors, most of the pathologists will look at this field, the center of the tumor. But I think the peripheral of the tumor is very important. It's help you, when you see these two, the first is a high-grade tumors. The second picture show you that it's infiltrative. It's going to the cortex, and you can see the entrapped neuron. Okay, another picture. Most pathologists will look at this piece, right? Because you have a lot of tumors here. But actually, the lower part is very informative because this is a cortex infiltrated by the tumor cells, and you can see a tumor cell trapped at the subpier surface. So with these two together, you can say that this is a diffuse high-grade glioma. Okay, so don't pay attention only to the tumors, the high cellular tumors. Pay attention to the area that have a less cellularity as well. Okay, next features that suggest a neuroepithelial tumor, fibrillary background. Both the glial and neuronal have a fibrillary but glial is more coarse and neuronal is more fine. Maybe it's subjective, but I show you. This is a fibrillary background in the diffuse astrocytomas. You can see like a brain background. Even with the H&E stain, you can see axon. And you can tell that this is an infiltrative glioma. You can see the entrapped neuron. Look at the background, it's quite coarse. This is a neurocytic neuronal. You can see, you can still appreciate the fibrillary, but very fine. Pineocytoma and neurocytoma, I think both are very similar. You can see the background fibrillary. Okay. Medulloblastoma, fibrillary. Especially if you have a medulloblastoma with extensive nodality, background is very fibrillar. So this one, is it a homovirus rosette or not? Yes or no? Yes. I'm not sure. It's maybe yes. Dr. Tang, do you think it's a homovirus? Vaguely formed. Sender. Yeah, yeah, not very well formed. Okay, another features, perivascular pattern. Okay, this is a perivascular pattern in ependymoma. Again, this is a perivascular pattern in myxopapillary ependymoma. Sometimes you get the pattern in glioblastoma. So this is a pattern that is not specific, but if you want to make diagnosis of ependymoma, you should have a prominent perivascular pattern. And just to comparison, I think it is entirely different. So in a perivascular pattern in glioma, you have a tumor cell sending a process toward the central vessel. Sometimes you get the microvascular proliferation. In lymphoma, tumor cells infiltrate angiocentric into the vascular wall. Okay, and you never get microvascular proliferation in lymphoma. Okay, so it's very different. Brain lymphoma, you should be able to diagnose with H&E. Okay, don't do immunostain. Immunostain just for classification. But most of the lymphoma in the brain is H&E diagnosis. So I don't, yes.
You can make a diagnosis of lymphoma during surgery and in the intraoperative.
Yes, we do the smear. Yeah. Yes. And we should be able to distinguish between lymphoma and glioma intraoperatively because the immediate management is different. Yes. Don't tell them high-grade tumor. Neurosurgeon is going to get angry because they're going to say, we know it already is high grade. Right. The next is the Rosenthal fibers. It's a corkscrew fibers. We all know that is a feature of a polycystic astrocytoma, right? Rosenthal fibers. But actually it can be seen in gliosis. Gliosis, usually at the cerebellum, suprasellar and spinal cord. So not surprising, you can get Rosenthal fiber around hemangioblastoma. You can get Rosenthal fiber around craniopharyngioma or spinal ependymoma. So this is the Rosenthal fibers in the polycystic astrocytoma. With this field, I think I cannot tell whether it's tumor or not. But actually, this is paragliosis adjacent to adamantinomatous craniopharyngiomas. So don't rely only on the Rosenthal fibers. So talk to the surgeon, talk to the radiologist, okay? Because sometimes I think if you don't see the epithelial at the upper part here, you cannot, you may call it polycystic, astrocytoma. The next is a rosette. Okay, rosettes still have some meaning. Homorai rosette. I think you're gonna find this rosette in the book, in the book more than in your routine practice. But if you see it, it's good. But if you don't see it, you can still make diagnosis of medulloblastoma. What about this rosette? This is quite typical in some tumor entities. So this is called multi-layer rosette, or in the past it was called ependymoblastic rosette. And nowadays is a hallmark of the embryonal tumor with multi-layer rosette. But I have seen that. I have seen two cases of a multi-layer ETMR. But rosette can be minimal, very few. But you can diagnose. But if you see it, it's really diagnostic. Perivascular rosette, I think it's still a finding that you need to find a lot in the ependymoma. Do not look for the true, because I think less than 30% of ependymoma has a deep rosette, but it's more specific, but it's not commonly present. Okay, secondary structure is, as I mentioned, is very helpful. And you have to be aware that in patients with epilepsy, you can get some increased oligo cells around neuron. You cannot do the counting how many cells around a neuron to be, there is no cutoff. But the clinical picture is different. So if the patient comes with epilepsy and you have a lobectomy, sometimes you can get oligo hyperplasia, and you can get more oligo around a neuron, particularly at the lower part of the cortex. But clinical is different. Okay, although I look at the slide first before reading the clinical. I never diagnose without clinical data. Okay. Next, okay, is a stipple-chromatin. Okay. This one I put a note here because endocrine, neuroendocrine, and embryonal tumor brow cells look very similar. This is a stipple-chromatin. So this is the oligo. This is central neurocytoma. And this can look like a pituitary as well. This is a stipple-chromatin, but in the high-grade tumors. Again, I keep the neuroendocrine and endocrine within the differential. So which one is, do you think this one and this one, which one is a small cell carcinoma? Which one is medulla? This is a medulla. Yeah, wrong. This is a medulla. This is actually small cell with the rosette, right? This is a homorai. You can get homorai rosette in the small cell carcinoma. And if you look at the very high power, I think they look very similar. But this is a finding. If you go to other areas, you can see some cheating here. This is more likely to be a small cell carcinoma. But in real practice, the clinical pictures are different, age different, right? Because the medulla above 30 is going to be very rare, right? If you don't have you can do immunostain to distinguish that. But in real life, it is a different clinical pictures. But I just want to demonstrate that the nuclei are very similar. Okay, pseudoparasitic necrosis. is a hallmark of the glioblastoma, but it can be found in high-grade glioma and even embryonal tumors. So this is typical pseudopolycytic necrosis in high-grade gliomas. Microvascular proliferations, again, is usually high-grade, but it's not restricted to a glioma. In medulloblastoma, you can have a microvascular proliferation and some endocrine too. And this is a microvascular proliferation. It's glomeruloid microvascular proliferation. You don't see this in lymphoma. Okay. Ganglion cells. This is a normal, abnormal. This is abnormal, but I took this photograph for a normal brain. I think that our brain has some binucleate neuron in the brain, but it's very minimal. So it doesn't cause any symptom. So don't rely on just one cell with the binucleations. Okay. So look at other cells. So this is from a gangliocytomas. You can see that you have a binucleate ganglion cells. You have many large ganglion cells. And this one is a ganglioglioma. You have a large ganglion cells, binucleate ganglion cells, and it is typical for ganglioglioma to have a lymphoid infiltration. And even you can make diagnosis of ganglioglioma without binucleate ganglion cell. You don't have to have it. Okay. Okay. What's next? Okay, I think today I wanna just focus on neuroepithelial and neuroendocrine. And for non-neuroepithelial tumor, you have to go over the list and try to memorize. And one thing is that the last one is the feature suggesting non-neuroepithelial is the absence of neuroepithelial features. So for the resident, how you gonna make your 10,000 hours? Okay, so this. So let's go for the quiz. Quiz. Number one. Okay. So look very pyeloid. Yes. Have a cyst. Cell has very long processes, very coarse. You have a rosenthal fibers. So this is something that when I look at the case, I don't rely on anything. I just make diagnosis. So I don't care about the location. So just call it parasitic. That's it. Okay, second case. Okay, we have a lymphocytic infiltrate. You have a glial tissues, have a neuron, have a binucleate. Not just one, two. So I think this is enough. You can, whether it's even though the cellular is not very common for this entity, but morphology is very characteristic. So just call it ganglioglioma. You can see sometimes we can still make diagnosis. You know, you don't need immunostain. You don't need molecular. Number three. Oh, what type? Okay, I'm glad Professor Tao mentioned about metastasis. I have in my practice, when I think of metastasis, I ask another question, whether it's adeno, is squamous, is hepatocellular, is neuroendocrine. Why I ask the second question? Because if I cannot put into the further subclassification, I have to rethink again whether it's a metastasis or not. I'm not saying that you are wrong. So this is a highly pleomorphic, right? Tumor high grade with necrosis. The pictures here, I try to show that it have a sharp demarcation. But the cell, if I cannot tell whether it's adenomas or it's a, yeah. And if I cannot tell, in this case like this, I will tell myself that I need special stent. Okay. I also have a glioma within the differential, but I think the cell doesn't look glial to me. Okay. You are the best. You're correct. So this is a metastatic polydifferentiated adenocarcinoma. We have a mucin positive, CK7 positive, TTL1 positive. Okay. Number 4. I think this is the most, this is the diagnostic field. So go back, it is a highly pleomorphic tumors. Not glial. And you can see this is a tumor cell infiltrate into the blood vessel, angiocentric pattern. So it is a lymphoma. So sometimes a tumor can be funny looking, but the behavior is the same. Okay. So we tell, I suspect lymphoma because of the I see this pattern, the angiocentric. Okay. So I don't need too many immunostain. Okay. Again, for the young resident. Okay. And one thing you have to have a develop. I think you should develop your specialty. Don't be general pathologist. I have no trouble with breast pathology with GI because I don't read it. I don't do it. I'm doing only neuropath and molecular diagnosis. So you have to be focused on something. You cannot be to be a good general pathologist is more difficult than to be a subspecialty. Okay. Okay, and lastly, before diagnosis, you have to consider clinical history. You have patient age, locations, and other imaging. Okay. Okay, so with that, thank you very much for your attention.
Yeah, thank you, Professor Shanop, for interesting presentation. Yeah, you can return to your seat. Oh. Yeah. Sau bài này có vẻ mọi người cũng có cần phải dịch chính xác không ạ? Còn không thì mình nghĩ cái chìa khóa của bài này là đầu tiên và nó cũng là cái nền tảng là phải là HE, tức là mình phải dựa vô hình thái tế bào. Nhìn cái slide trước đã, trước khi mình nói tới là những cái xét nghiệm sau đó như là hóa môn dịch hoặc là sinh học phân tử chẳng hạn, ít nhất cũng phải biết được là bất thường hay là bình thường, kiểu cấu trúc gì và thay biến đổi tế bào như thế nào. Thì chủ yếu là trong cái bài này chìa khóa của nó là HE. Chúng ta sẽ có khoảng 10 phút nghỉ giải lao và sau đó mình tiếp của một cái bài báo cáo tiếp theo sau đó. Thì trước khi mà nghỉ giải lao á, thì